Good afternoon, everyone. We know that people are just joining. We are excited to begin our webinar in just a few minutes. We still have guests who are registered who are joining. So take a moment if you want to grab a snack or beverage as we settle in. I just want to thank everyone for joining our conversation today on COVID and the child welfare system. We'll give everyone about one more minute before we get started. Thank you. All right. Good afternoon. My name is Annette Campbell Anderson, and I am your moderator for this afternoon's conversation, COVID and the child welfare system, moving from a pandemic to an endemic. And I'm really thrilled today to have with us as our panelists three experts in our field to discuss the impact that COVID has had on the last 3 years overall, and then for us to kind of take a deeper dive into the child welfare system and to look at the impact that has been had there as well. So before we get started, I want to introduce our three guests and panelists today. Our first guest is Dr. Panagis Galiatsatos, who is an assistant professor at the Johns Hopkins School of Medicine in the Division of Pulmonary and Critical Care. He is the co-chair of the Johns Hopkins Health Equity Steering Committee, and he is also the co-director and co-founder of the novel medical initiative, Medicine for the Greater Good. A Baltimore native, he has published over 40 research articles with a focus on health equity, community engagement, and contextual level variables' impact on health outcomes. During the pandemic, Dr. Galiatsatos and colleagues coordinate community engagement to ensure all populations were able to access COVID-19 updates and resources in an effort to assure compliance with public health requests. Welcome, Dr. Galiatsatos. Our next guest is Chandra Chester. She is a social worker and co-founder of Families First Counseling and Psychiatry. She has experience in child welfare and providing therapy to individuals, families, and couples. Chandra holds a Master of Social Work from the University of Maryland in Baltimore and a Bachelor of Science in Psychology from Salisbury University. She is a licensed clinical social worker in Maryland and is also an approved supervisor for social workers, counselors, and substance abuse counselors. She specializes in PTSD, anxiety, and depression, and is an advocate for marginalized communities and passionate about breaking the stigma around mental health in the Black community. She is also a safe space for those in the LGBTQIA community. And then finally, I would like to welcome Mr. Stephen Liggett-Creel, who currently serves as the director of the Howard County Department of Social Services since January of 2020. Prior to that, he served as the chief of staff for Prince George's County Department of Social Services, providing leadership for the agency's operations, child, family, adult services, and the county's community school program. As a licensed clinical social worker, Mr. Liggett-Creel has over 20 years of industry experience and strong ties to the DHS family, having also served as a social worker for Baltimore County and also at the ARC of Baltimore as a social worker for several years before joining Hearts and Homes for Youth. First as a program coordinator with their therapeutic foster care program, and eventually being named as their vice president of therapeutic services. He also has spent 7 years as a member of the Howard County Mental Health Authority and served in transition of the agency to the local county government. And he currently serves on the Association of Community Services Board. Welcome to all three of our guests this afternoon. Great. All right, so we're going to start with you, Dr. Galiatsatos. I want to just let you know who's in the room today. This afternoon, we're speaking with, we have registered approximately 20 resource parents and another 70 child welfare workers and staff members. And so I wanted to start with an overview from your perspective of where we are with COVID in terms of the transmission rates, the current positivity case rates. Give us some insight into just where we are to set the stage for today's conversation. Thank you.
No, of course, a true honor and a true honor to be amongst these amazing panelists as we navigate these waters during still a public health crisis. Though June 30th, 2022, we are in a much better place than we were, 2020, 2+ years ago. And where we're at, it's a great question. So let me tell you where Mother Nature is at, and then I'll tell you where we're at and how we continue moving forward. So Mother Nature is doing what she does. Every living thing will evolve in order to try to make sure it can find a good permanent place amongst the rest of us, amongst the world. And what we've seen with the SARS-CoV-2, the virus that causes COVID-19, as it has progressed and changed, Omicron and its subvariants have actually found kind of the Goldilocks of what that they want. High transmission, easy to infect us, and lingers with us for quite some time. We cannot forget the virus needs us to live. Can't live by itself, and it doesn't want to cause us to go down with it, right? Because if we go down, the virus goes down with it. It has found that nice Goldilocks. Now, with that said, it's a big concern from our standpoint because it seems to readily affect most everyone, and at some point, it will find more vulnerable populations that will cause more dire health outcomes. So Mother Nature has kind of found the right ingredient for Omicron in all of its evolutions. However, from our standpoint, we have two good interventions to make sure that Omicron is not seen as a catastrophe for us. First, we have the appropriate tools to prevent severe COVID. And make sure you guys understand, to prevent severe COVID. Meaning, we have the vaccines. They weren't created to stop transmission. They were created to prevent severe COVID, prevent a life-threatening version of COVID. I always tell people it's like wearing a bike helmet. Bike helmets don't stop you from falling. They just keep the fall from being too much of a health risk. And we also have great medications as well. So we can stop severe COVID. I, as a critical care doctor, can tell you the last 2+ months now, I've cared for less than 10 patients in the intensive care units with COVID. We are doing great. However, there's a high community transmission rate. And so from my standpoint, the second tool we cannot forget is the face mask. If you don't want to catch COVID and be grounded in your home for about 14 to 21 days, not even knowing if you're going to be set up for long COVID, it's still the face masks. Those are key weapons as we go out, key tools as we go out into the public and so forth. I'm going to quote for you one of my patients, and I'll leave it at this. She comes into clinic and she goes, Dr. G, I'm always going to wear my face mask because I'm not catching COVID from strangers. I love that mentality, right? You're going to go out, do shopping, you do you. You can still live perfectly fine knowing we have a tool to not catch this infection. And of course, if you're with loved ones, our guard does go down, but talk to them. Any symptoms today? You're feeling okay? Great, let's hang out. So we have the tools to not catch it, not spread it, and to keep it contained. Last comment, we have now vaccines 6 months old to 60+ et cetera. So everyone can have that protection, which is amazing for a lot of parents who, for some of us, we haven't left March of 2020 with our young ones, and now we can feel the confidence in it. So yes, we've come a long ways. And from my standpoint, I'm hoping we continue improving in this public health crisis.
Thank you. Thank you for that update, Dr. G. And to our audience, I just want to invite you to ask questions of any of our panelists today by posting your questions in the Q&A so we can make sure that we are monitoring your questions and we can ask them directly of our 3 panelists. So I want to go back really quickly to you for a moment, Dr. G, because I want to find out, given that, we are now in the place where, as you said, we're more likely to live with this, and that you're seeing fewer and fewer cases actually in the ICU. Does that mean that we are getting to the end of the pandemic? Is that what that is signaling? Are we going to see this starting to wind down? I mean, I know I just found out that someone that I'm close to tested positive, but it's also more seeming like a cold or the flu these days. So are we looking at the end of this pandemic anytime soon?
So I'm gonna we're here, we're all transparent, we're honest and so forth. I would look, and I'm going to give you a conservative estimate. And so if I'm wrong, fine, if it ends sooner. The pandemic, there's two endings, right? There's the Mother Nature's ending, and then there's kind of the political cultural ending. And for many of us, we're seeing the latter, the more political cultural ending. Mother Nature's pandemic probably is going to stick around for another 2 to 3 years. And that just means taking the proper precautions, because while I discussed the evolution of where the virus is now, the virus isn't a person, right? I don't want to anthropomorphize it. Doesn't know if that's the way it wants to stay, right? Its next mutation could be just as lethal as Delta. So from my standpoint, I think we stay on guard. We are definitely at a better time than than 2 years ago, but I wouldn't call this near the ending. I think we're probably still 2 or 3 years from that. Now, it doesn't mean 2 or 3 years of living in fear, just 2 or 3 years of living, staying up to date and knowing how to navigate these waters. I will also say science on our end. We are trying to come up with better tools to even stop transmission beyond the face mask, like a vaccine that can even do just that. So, science is trying to keep up with Mother Nature. My conservative estimate is 2 to 3 years to ending of a pandemic, and then it will probably just stay epidemic here and there. But that's it. Again, I didn't say this to scare anyone, just getting us in the right frame of mind and recognizing that this is just what happens with viruses.
Yeah. So Dr. G, we're here today because we're speaking with those who are in the child welfare system, both the staff members as well as resource families. And so as we know, that requires a particular sense of attention to care, for example, when visiting with biological families as well as foster care families, for example. Do you have any suggestions for how we might continue to mitigate spread, asymptomatic spread, especially for those who are involved in the child welfare system, within the resource parent homes, for example, and for children? Any thoughts on that?
Yeah, and it's a great question, because one of the things that I'm hoping for, and I'm going to answer this by kind of telling you a hope it's a biased hope, but as a lung doctor, as a healthcare professional, my patients before the pandemic kind of evolved to these new social norms of talking to loved ones to make sure they're feeling well. Hey, because don't come and spread your germs, right? Because I see this from that standpoint, every lung doctor at least recognizes I can stabilize your lung disease, an infection will always rock it, undo it. And so those human beings are practicing that. And now where I'm at with the pandemic is we need to make this kind of just a new social norm. Right? You want to invite loved ones over, you want to invite people over, you got to just check in with their symptoms. And if you feel comfortable enough, if it's allowed professionally or personally, by all means, ask for their vaccine status. Because the vaccine, one unintentional but really good outcome of it is the vaccine seems to have stopped asymptomatic spread of this virus. That's huge. Doesn't mean you can't spread it, but it just means you'll spread it if you have symptoms, which hopefully just means you're easier to identify. So yeah, Dr. Anderson, my hope, my plea is that we accept these new social norms of responsibility of like, I have germs, I shouldn't spread it to you, not just COVID, any germ, right? No one needs a cold. So from my standpoint, the best way to mitigate this, I think it's on our shoulders now with all, the mandates on and so forth. It is having these conversations with loved ones, making sure they feel fine. If there's any concerns, maybe a good quick home test in the morning, or just wearing that face mask when you go out into public, right? That's still a huge way to mitigate spread. The face masks are a great tool. So Dr. Anderson, I'm hoping today, 12/31, June 30th, we begin to continue planting the seeds of a social revolution to really stop one of Mother Nature's requests of us. Mother Nature wants us to be ignorant of this, right? Because that way these germs and viruses can continue to spread. So from my standpoint, let's undo that. Better than that, it just takes just a bit of courtesy and humility to make sure you don't go and spread this.
And how important at this point is social distancing? I mean, especially when you think about the child welfare system, for example, and children who are being placed in homes and the resource parents trying to make sure that they are also staying safe while attending to the care of young children. How important is social distancing still?
I would say it's a tool, but it's not one that's going to be easy to apply and implement and so forth. So from my standpoint, I would say, hey, yes, it's a tool there, but it wouldn't be my top 3 of most important. To me, if someone is sick, say with COVID, face mask. I can quote you tons of data, but let me just quote you a personal narrative. I had a 4-year-old sick with COVID. I wear my face mask around her. 2 weeks of her testing positive, I didn't catch COVID. It works. It's a good tool. Right? We can still engage with our everyday lives, just with an extra layer of precaution. So from my standpoint, face mask is by far the best tool to allow us to engage, allow us to be human beings with people and so forth. So yeah, physical distancing, social distancing, it's a tool, just like I'd say a lockdown's a tool. But where we're at now and adapting to things and assimilating with it, I don't think it needs to be a top 3. I think appropriate testing, monitoring symptoms, keeping people up to date with their vaccines to eliminate the asymptomatic spread, and then the face mask if someone should have any question or concerns of germ spreading, or someone is contagious or has COVID and they want to protect themselves and others.
Okay, I thank you. I'm going to come back to you, but I want to go to one of our next guests, to Ms. Chester. Can we talk a little bit about how COVID has impacted children? I know that the impact of COVID has just really been so pervasive, because it has gone on for a much longer time than anyone thought it would. But also we're seeing that it has affected the mental health, and sometimes in some cases even the physical health of our young people. What would you say is the ongoing mental health impact of COVID for children and families?
Well, I'm going to start with just a few statistics from the CDC to kind of put things in perspective. So prior to COVID, you had about 1 in 5 children that had mental health disorders, right? But only 20% of those children receive any care. In 2020, it was reported by about 71% of parents that their children were then experiencing those mental health disorders. Emergency room visits went up by 24% for those ages 5 to 11 and 31% for those ages 12 to 17. That is a lot of kids in the emergency room for mental health issues. And when you talk about adults, about 4 in 10 adults prior to COVID had symptoms of depression and anxiety. I'm sorry, post-COVID have symptoms of depression and anxiety. And then before that was 1 in 10. And there's been a huge spike in African-American youth and young adults, also in Indigenous people and other people of color. So you're seeing a huge rise in people of color since this pandemic who are experiencing mental health crises, especially you got your caregivers, your frontline workers. It's been a huge increase. Then if you add on top of that, they're losing employment, right? And then you have those kids who are living in poverty. They only ate food when they went to school, right? They got that love and that physical touch and that encouragement when they went to school, because maybe they're in a household that's not only in poverty, but where they're experiencing trauma and abuse. So essentially, COVID sent kids into the fire like 24 hours a day when they got kind of some relief from that fire when they were able to go to school. So I see that being a big part, because even deaths of children increase when the pandemic, child abuse increased significantly when the pandemic hit. And add on top of that, the isolation, the lack of social skills, being home trying to do schoolwork, those with learning disabilities, how does that make them feel when they're trying to do work over a computer? And to put it all in perspective, today, like if you call a mental health clinic or private practice agency and say, hey, I'm trying to find therapy for my kid or for my family, they're going to tell you that they either are not accepting clients, right? Or there's a 6 to 8 week wait list. So if you have a family in a mental health crisis and you're told you have 6 to 8 weeks that you have to wait to be able to talk to somebody about your issue, what are you supposed to do with that? Right? And so then you have either those who go to emergency room or those who unfortunately choose other methods to deal with the issue, whether it's substance abuse, whether it's suicide attempts. And so we see a huge increase in that, and also a decrease in those going into the mental health field. Enrollment is down at some of these schools for mental health providers, right? And then you have people leaving the mental health field to go be hostess or bartenders. Anything that doesn't require them to take on all that stress, all those stressors from those families.
Exactly.
And so A huge
So,
impact.
so how has the pandemic in essence then affected the capacity of child welfare workers to be able to, do their jobs well? What has the impact of the pandemic meant for the child welfare system?
Well, they were already busting at the seams before the pandemic, right? So astronomical caseloads. And so can you imagine now with the increased reports of child abuse or people unable to take care of their kids? So piling on piling on piling, and then you're responsible for the well-being of these kids. And if somebody slips through the crack, now you're liable, right? Now you're on trial or you're being charged with some type of neglect or not doing your job, right? And so I think it's extremely hard for them to do their jobs well during this time. It was already hard prior to the pandemic.
So I don't think it's a stretch to say that many of us have COVID fatigue at this point. And I think I think that you just spoke to that in particular for the child welfare families, as well as the resource parents. I mean, this is has been a huge stress for everyone. What are some strategies that you might advocate for so that people can feel just less stress or so that they have a plan to be able to manage some of the stressors that people have been trying to navigate for the last 3 years? I think part of the challenge is that no one expected the pandemic to last this long. And we just heard Dr. Galiatsatos say we could expect this to go on for another 2 to 3 years. So what are some strategies that you think that staff in child welfare should be considering or adapting or adopting, because everybody can't become a bartender? We still need staff to be able to work in the field and do the work well. What do you suggest, Ms. Chester?
Well, I would say for the staff and the parents, it's kind of the same type of strategies that can be used. Number one, movement is extremely important, right? Moving your body, whether it's dance, whether it's yoga, going for a walk. It's extremely important just to keep you healthy and keep your mind clear. Also, creating proper sleep hygiene, coming up with a routine. What does that routine look like? If I ask right now, who has a sleep routine, how many people would raise their hand and say yes, right? Because nobody thinks about, okay, what does that look like? How can I make sure I'm getting enough time, getting proper sleep? Limit how much you're focusing on the news. There's a lot of stuff out there right now. You don't need to deal with COVID and all the other stuff that's going on in the world as well. So definitely limit your news. Talk to friends, right? Get a therapist. There's support groups out there for different things. Practice mindfulness. Part of my routine is belly breathing, meditation, journaling, right? And so I make sure to do those things so that I'm grounded and I'm aware of what my body is doing. Show yourself some grace, have some self-compassion, right? We're not perfect. We're not going to get it right all the time. So just being kind to yourself, do some fun stuff safely, but have fun. And more specifically to the caseworkers, don't be afraid to set boundaries. A lot of times, especially new coming out of school, we get into these positions and we think we have to. We don't. If we're to that breaking point, we have to be able to communicate that we're to that breaking point, right? Don't take work home. If you're working from home, have a designated area that's for work. And when you come out of that area, work should not be a part of your life after that until you go back to that space. Use the word no. No is very important for good mental health. Communicate with your supervisor. If you're feeling stressed, say that, right? If it's a caseload issue, say that. Document these conversations so you have something to support. You go into your supervisor and say, I need help, I can't do this. Most agencies have EAP, so Employee Assistance Program. Use it, it's free. You get so many sessions and then maybe that's enough, or maybe you need to seek a therapist. Supervision is a space where you should be communicating your needs as well. That could be a support. PTO is always a great one, right? Take that time off and recharge and protect yourself. But most importantly, come up with a self-care routine that works for you. Like I said, mine includes belly breathing, body scans, monitoring what I eat. If I notice I'm intaking too much sugar, I'm like, whoa, whoa, whoa. I need to get outside and move. I'm obviously in a space. Something's going on. Let me check in. I must not be present, right? Practicing good sleep hygiene. I take voice lessons and I love karaoke. So that has been getting me through the pandemic, because pandemic fatigue hit me hard in the beginning. And so I had to readjust my self-care routine. And so in doing that, now I've been able to function much better now that we're on kind of on the upswing of it. And that's what I would suggest.
Thank you. Thank you so much. And we're going to come back to you as well, Ms. Jester, but now I want to go to Mr. Liggett-Creel. Mr. Liggett-Creel, can you talk a little bit about direct practice and thinking about how direct practice has been influenced by COVID? Has it impacted how child welfare staff reach out to families? Has it impacted how those families interact with the child welfare system? And has there been an impact on, for example, training for the resource parents? How has COVID shifted the work that families do, as well as the child welfare staff do in the child welfare system? Thanks.
Yeah, thank you for the question. So, I think first and foremost, child welfare work, whether it's the worker or the resource family, really required a relationship building between all the parties, right? Parenting in that system is not, is a unique experience, right? Where you're having children in the home, you're working with children, and you have multiple households and caregivers that you have to account for. So I think that what COVID did bring is the necessity to continue to build and maintain and engage in relationship with all parties. The added component, I think, you talked about a training and how we engage, right? The added component was we now have an added topic that we have to bring to that table. And that is not just as we're working through what is necessary to stabilize the child, to stabilize the household, planning for the future of a particular case, but we're having to also include conversations around the things that Dr. G talked about, right? We're having to include conversations around, how are you feeling, symptomology, personal feelings and concerns around COVID exposure, extended families' health, right? We're having families where we're having to now account for those household members, but we're also then having to account for other pre-existing conditions that are at risk for COVID exposure. And then as a workforce, we're having to bring that additional education to our homes, additional education to the resource families, and additional education that systems have to provide for their staff, right? Because they need to know the current science, understand the changing evolution, right? What we know about the COVID in March of 2020 is vastly different than in June of 2022, right? And so we're having to keep that all parties on top of that and keep it on top of the science available, right? And try to parse out between kind of what is just floating in the atmosphere versus what is true and reasonable to know. But I do think it still fits in that relationship to have those conversations, and it's just broadening the kind of topics, right? And having to ask questions that maybe we never had to ask before, where maybe someone had a sniffle and we could kind of just, ignore it in that moment. Now it has to be a topic of conversation. We have to engage prior to visitations. And I think it does also, it has forced, and this is real, right? It has forced some change of boundaries around, resource parents protecting some health issues from the biological families and vice versa, where now we're kind of having to share that because we need to understand each other so that as we come together in whatever capacity, we understand the risks that are being brought to that particular table. So I think it's just an added level of understanding and knowledge in an already existing necessity to have relationship with all the parties involved in this particular child's life.
So I really appreciate your insight on that, Mr. Liggett-Creel. I know that we had earlier had a conversation, and I learned that the bio family has to approve the child getting the vaccine. And so what happens if there is some disagreement between the resource family, for example, and the biological family about the status of the vaccines or the boosters. So if the biological family disagrees that vaccines are necessary, but the resource family wants them, what happens in that situation?
Right. So when we're engaging, so I think the first point, and we work really hard to try to make sure our resource families, and I think most resource families understand this, right, is that the bio family is still the family, and they're still involved in the decision-making of this child until decisions otherwise have to be made. And so I think most resource parents understand that, right? Again, it comes back to, understand, if we're talking about a disagreement between the resource home feeling like vaccination is necessary and a bio family not wanting it, again, I think that comes back to that's another area where we're having that engagement with the bio family to really understand why, right? And then understanding the risks to the resource home, and in the end, trying to make sure both parties are aware, and then what intervention can be done to avoid, having to maybe remove a child, right? Because in the end, that's what we don't want to happen. But it again requires that engagement in relationship and truly understanding it, and again, making sure we're communicating between those two parties. There's going to be lots of times in all cases, right, where there's a disagreement, whether it's COVID related or not, around a particular action. But the fact is that, that parent has the right to make the decision. We as a system want to try to help that family explore, and using our medical professionals like Dr. G to help support maybe why they need to consider another option. But when a family has explicitly said no, we're a family-centered system, right? And so we have to kind of respect that, even if we disagree with it, and we have to help our resource families understand that too. But again, that's part of our onboarding of most resource families, right? This is what, this is the role they play, and they've signed up for it. And I would say the vast majority of them agree and wholeheartedly support.
Awesome. Thank you. All right. So I want to remind our audience that we are here to answer your questions. We've got quite a few questions actually to get through for our panelists. So I'm going to go back, and I want to start with you, Dr. G. Can you talk a little bit about the BA.5 variant? And the question from this audience member is, aren't most of the cases currently connected to this variant? And how are vaccinated people responding to the variant?
So the person is correct to some extent. It is the most predominant variant in a lot of regions. And this variant in those who have been vaccinated. So pause real quick. Vaccine, the one that we're still using, was the one that was created around the Alpha variant. And it was amazing around that variant to prevent severe COVID-19. Now I say this because the vaccine has still continued to stay pretty good against the newer and newer variants. The caveat is, even with the newer changes, especially with this one, you need to really have a good amount of antibodies, right? So that's the one thing we haven't needed a newer vaccine. We just need to make sure that we have the appropriate amount of antibodies. That's why we recommended a booster, and then for some populations, a second one. So if you've been boosted, yes, if you catch this virus, this variant, it'll be a bad cold. And I see this because everyone, I don't want to negate how people feel and so forth. The one concern I have over it, two concerns, because this is going to impact transmission. One is your initial symptoms of it are very insidious. I actually call them dismissive symptoms, right? You got a bit of a runny nose, a little scratchy throat, don't think much of it. We wake up like this a lot of times. You go about your day, don't think of it. 3 days later, you get a fever and oh my goodness. And if a doctor presses you, you're like, well, I did have that scratchy throat 3 days ago. That's where we're pulling our hair out and going, who did you engage with? So that's my frustration with this. And the other part is the other end of it. It lingers, right? You can still test positive up to about 14 days. Now, you can go back out into the world masked, so you're not spreading it because you're still contagious, just not as much as you were maybe during the height of it when you had fevers and so forth. But my frustration with this newer variant is, and does well, if you have well vaccinated, it's going to protect you. The Paxlovid, the medications are also really efficacious against it. My frustration of it from a transmission standpoint is the dismissive symptoms in the beginning and the tail end of kind of a prolonged contagious period. So that's where I'm at with this virus.
Thank you. And just as a follow-up to that, we have another question about booster shots. So we know that the vaccine has now been approved for children under the age of 5, but how long should families wait in between vaccines before they get a booster, and how often should they be boosting?
So, and Dr. Anderson, I'm going to imply the question means just in general with vaccines, how long should we wait? That answer is actually, you can go about pretty darn quickly. I mean, to everyone, it's kind of a personal choice because you're like, well, I'm going to be really miserable. Do I want to be miserable now and 2 weeks later, or do I just want to be a little bit more miserable tonight? You know, for those of you who've ever been to the military, I mean, some of them get 18 shots in one sitting. Let me take this back real quick, right? Because you might be like, that's a lot. Our immune systems make antibodies every day. Like, we're all sitting here nice and calm and cool, collected, as our immune system's keeping every microbe that lives on us and in us at bay. And if there's a new one that we took on that moment, it's making new antibodies. Our body does that consistently. And whether it gets it in from nature's bugs, you know, into us, or because of a jab, the body just knows to make antibodies. That's not novel to it. You're not going to overwhelm it, or, you know, it is, I promise you, this is how it functions. So from my standpoint, you don't necessarily need to wait unless you feel like, you know what, I'd just rather spread out, you know, my symptoms and so forth. So biologically, there's not a reason to kind of postpone. Now, if the question is though, COVID boosters, Dr. G, let's talk about those. From my standpoint, once you finish the initial series, and keep in mind to the parents of 6-month-olds to 4-year-olds, if you want to get the Pfizer one, that's a 3-shot vaccine right off the bat. All right, so just keep that in mind, keep that in mind. So to complete the initial series, once that's done, waiting 4 to 6 months for the next booster is fine. For a second booster, this one I really ask you talk with your doctor to have him or her discuss, are you the right candidate for that second booster, right? Do you have some pre-existing health conditions that warrant it? Are you of a certain age that warrants it? That's what I would plead. I'll finish with this, Dr. Anderson. The FDA is reviewing an Omicron-specific vaccine, which would be great. The timeline, I don't know what their decisions were after that, but the fall may be a vaccine, no longer the Alpha, but now for the Omicron, which, you know, if Mother Nature doesn't do much more, may be the only vaccine we need for the year. So more to come, and the HEAT core group will be one of the first people to know, and we'll update you.
Absolutely. Thank you, Dr. G. I want to move now to Ms. Chester. So this is also a question that we have from one of our guests today. Do you think the pandemic has exacerbated the mental health crisis? And what do you think the consequences will be potentially in the long term?
My answer to that is absolutely. And I think the long-term consequences will be, you will have a lot more people applying for a disability. You'll have a lot less people working, right? And then you'll have a system that continues to be overwhelmed. Right?
Talk a little bit more about that. That was pretty stunning. So talk a little bit more, unpack that for us a little bit more. Thank you.
Okay, so think about it, right? Say you have a predisposition to mental health disorders, maybe bipolar disorder or whatever it is. And this pandemic kind of triggers that, right? A lot of times what you see is, my experience is, you have people who aren't necessarily med compliant when it comes to particular mental health disorders, right? And so you have this constant cycle of stabilization, and then you're unstable. Or you get so depressed that you feel like you can't work, you can't hold a job. You're constantly losing jobs, not showing up, getting fired. And so the alternative is, if I'm going to take care of myself, I'm going to need money coming in. So let me apply for disability, right? We already have people that apply for disability that really can't maintain employment. And then you have Department of Rehabilitation Services. They're so overwhelmed that the wait list is at least 4 years, if not more, to get those additional services, right? To help you with supportive employment once you have these mental health disorders. So I see the economy really being impacted by it and having less people working. That's just what I see.
No, I think that that's pretty powerful. And then, what do you think for our younger children? And I also want to ask Mr. Liggett-Creel to weigh in on this one as well. So, if as the pandemic has really unearthed this just tranche of mental health stressors that our young people are facing, what do you think the impact of that long term is going to be? I mean, we're seeing schools trying to find additional counselors. We're seeing schools trying to find additional school psychologists, social workers, all of the helping professions, the helping hand professions are being called on deck. And yet it seems to be, in a way, a shortage of all the available resource staff to help with this. So what do you see as the long-term impact for our young people of this because of this pandemic, for both you and Mr. Liggett-Creel to answer? And then what do you think we should be doing now? Because we're also seeing, this image of so many social workers and school counselors just walking out the door to become waitresses and bartenders is now firmly fixed in my mind. And so I'm just really wondering, what should we be doing if people are saying that they don't want to stay in the field because they're just burned out because of the stress that the pandemic has wrought?
I think we have to bring more tools like wellness into the workplace, right? We have to really look at how can we get more people in. Money, honestly, is one of those things. The people that work in our field are underpaid, right? Really underpaid. The same amount of money I was being offered coming out of grad school in 2006 is what's being offered to grads coming out in 2022 right now. So if I'm being offered $45,000 in 2006, why are they being offered $45,000 in 2022? Right? And that's why you have people trying to go to private practice and getting private pay. And most of the people seeking mental health services, they can't afford private pay. So you have that part, and then you're going to have a whole bunch of kids who can't regulate their emotions because the pandemic has created a whole bunch of parents who can't regulate their emotions, right? And so it's a vicious cycle over and over again. So you have these kids who don't know what to do with all these feelings and all these emotions in a classroom where we expect them to retain information. And then the classroom can be so rigid, right? So it's like, sit down, face forward, stop making that noise, and learn this information when they're trying to deal with all these emotions and while they're in school.
Wow, that's heavy. Mr. Liggett-Creel, do you have any thoughts on the same topic?
Yeah, so, I think first and foremost, we have a whole generation of young people who get exposed to a variety of topics that are stressful. Sometimes they don't understand the ramifications. The amount of information around either just a single topic that they're bombarded with, right? That in and of itself can add to the stress and anxiety a young person handles. We also have to just remember, right? Like, we have a whole generation of young people who had their entire lives disrupted. Everything that is quote unquote normal for young people was disrupted. And they learned that there was this thing that could cause death, right? Because initially that's how COVID was presented. It is a virus that can cause death. So the adults were stressed, right? We know that when adults are stressed, that changes dynamics between whether it's parenting or the empathy or the caring that an adult can share to the child, whether that's their child or a foster child, a child in foster care, or a neighborhood child, right? So the whole system is stressed. The other thing that all the folks watching this webinar can relate to is the other thing child welfare often sees is we get young people in who had issues many years ago that were unaddressed, right? And so now what we have is an unaddressed mental health issue, unaddressed behavioral concern that was allowed to exacerbate for whatever the reason, lack of resources, lack of understanding and attention. And now the system has to get involved because of whatever, right? And I anticipate that we'll continue to see that for many years, right? Because although there's a lot more awareness of mental health, we're seeing a lack of resources, the inability and the struggle to get into services. Ms. Chester spoke to it. I mean, we're experiencing, 2 to 3 month wait lists to get persons into care. But that anxiety is going to sit there. It creates a traumatic response. That traumatic response gets behavioral, becomes a behavioral adaptation to our young people. And I think it'll continue to put stress on the system. And so that early intervention, both from how do you engage in early intervention for the young person, but also from a system, speaking to the things you brought up, right? There needs to be early intervention in the system. And how is the system going to adapt to the current environment, whether that's resources or a rethinking of how we provide services. And I think there's lots of innovative ideas out there, right? It's about getting the populace and political will to implement those things.
Thank you so much. That's a really thoughtful response. I want to go back to you, Dr. G, because we have another question, which is actually very interesting. At the beginning of the pandemic, everyone was racing out to big box stores, trying to load up on supplies, like cleaning supplies, toilet paper, paper towels, and wipes. Wipes were given as one of the essential pieces of the armor against this pandemic. Do you still highly recommend that people follow these stringent routines in terms of cleaning their houses with wipes and wiping down surfaces with wipes? Is that still a valued method of trying to keep this pandemic at bay inside your home?
So one of the most humbling things about science is, everyone, and not even just science, but just physicians as well, and clinicians and nurses and so forth. You try to make the best hypothesis based on the data you have at that moment. And I see this because the humbling thing about the pandemic, I remember just always, even this, like we'll finish, I'm like, keep in mind what we say today could be wrong by tonight. It just came at a much faster pace early in the pandemic. So when we got this virus, it's a coronavirus, it's part of that family. We know this virus can infect you breath to breath, sneeze to sneeze, cough to cough, talking to talking. In addition to, on surfaces, its cousin, SARS-CoV. Because remember, this is SARS-CoV-2. We got a sequel that we didn't want. A virus back in 2003 in Southeast Asia, it actually did, a lot of infections did come from surfaces, right? People would touch them, then touch their nose, eyes, and mouth. So by all means, Dr. Anderson, you were right. We really were emphasizing, hey, don't breathe out, mask, and clean, wipe down. 2 years later, what we found out though is SARS-CoV-2 is actually rather fragile. Not an ego thing, but like its actual structure. So meaning when it lands on a surface, it's ticking away. It's got like maybe minutes, maybe at the most hours, but that's not where I'm looking at for anyone to get infected from. So I would 100% encourage proper, infectious control. This is not Dr. G saying stop wiping things out. No, wash your hands, right? Just be courteous. But we don't need to overdo it. And I'll say this because if you're like, oh, let me Google, Dr. G, look, there's science that says we can find this still months later. Well, not months, we're like up to a month later. And I will report back to you, you're right. We can find fragments of this virus on surfaces for quite some time. It's like finding a bone in a graveyard. Yeah, that's a remnant of a human being. It's just not a human being. So this virus is very fragile. On surfaces, it's gonna probably die off within minutes. So I wouldn't be at all looking for that to be a source of infection or to be infected by. So just go back to your usual routines. I just want to make sure that's clear, because I think one time the way people interpret it, like, oh, does he mean I don't have to wash hands anymore? No, you do. There's still germs out there. Just yes. You don't have to overdo it.
Okay. So what about masks and contact tracing? So you did say you think people should continue to wear masks in their everyday situations. And then contact tracing has been something that has also been a little bit controversial, because you do have some organizations that, for example, schools are doing some contact tracing. Some places had started contact tracing. They even had courses that could, to develop you as a contact tracer. So how important is contact tracing in this current milieu?
So contact tracing is definitely an important tool early in the pandemic, just so we can get a good sense of where the heck this is going. How is it spreading? Right. right now, for instance, we're seeing that with monkeypox, right? As we're trying to understand where the heck this is coming from, where is it going? And a lot of it just has to do so we can just understand the biology of it, right? If it seems to spread in a manner that, hey, we thought this was just skin to skin, but it shouldn't exponentially spread. By that, I'm thinking of monkeypox. So contact tracing is definitely important early on, just so we can get a sense of, being confident to be able to tell the community, we think it spreads in this fashion. Why do we think that? So if you look at contact tracers and they map out how this goes on, we see that kind of exponential or linear passing on and so forth. So definitely an important tool early on. Where we're at now, still valuable, but really its value and doesn't need to be as heavy as we were in the beginning. Its value is probably just more for, companies or businesses to make sure, are they potential super spreaders, right? We see this a lot in schools. Hey, 3 kids got COVID and people are like, oh, the school's passing it on. Well, if you contact trace them, you realize, no, those kids came into the school with COVID, not that they gave each other COVID, right? So contact tracing, I would still encourage businesses and schools to have, so you can have the confidence of, did the COVID spread amongst my recipients here, amongst my students, or did my students happen to just bring it in, right? That's key here. And, from my standpoint, I think that's where contact tracing still has a value in order for businesses to feel confident they're not spreading it internally. And actually, I'll finish with this. This is where, every school's strategy should still be making sure we hold these town halls, because parents need to understand COVID spreads at schools if you bring COVID into schools. So that's key from that standpoint. So Dr. Anderson, you're spot on. Early on in the pandemic, yeah, it's needed. We gotta get a good understanding of the biology of this and try to contain it as much as we can.
Yep.
Where it's at now, it's more of a tool to make sure, people are doing the best they can to not have events become super spreaders.
So we're headed into a big holiday weekend. Everyone is thrilled. They're going to see family, they're traveling. People are finally feeling a little bit safer in terms of getting out of the house. Everyone's feeling excited about the holiday weekend and vacation over the next 6 to 8 weeks. What do you think that portends for fall, Dr. G? What does it mean? Because it seems like when we did that for over Thanksgiving, we got hit with Omicron, and that was a big national lesson for everyone. So what do you see as the way we're going to roll into fall and with all this travel that's happening this summer?
So, and it goes to, making sure that we have to have these conversations like, hey, how are you doing? Do you feel great? Great, come in. Let me give you an example, for instance. And maybe it was because it's my side of the family. They were like, oh, shoot, Dr. G's going to be at this wedding. So we got to make sure we do the public health things. We went to a family wedding and the bride and groom made it clear, if you don't feel well, stay home. And then self-test Friday and Saturday, 2 negative tests, come to the wedding. Everyone was negative, and to date, no one has had COVID from that wedding. It was about 100 people too, right? So, hey, we got to celebrate. So I'm saying you can do these things well without the ramifications. You just need to take these extra precautions to do just that.
So it sounds like you're suggesting a testing strategy for public events, for gathering events. So if you're having a family cookout, if you're having a family reunion in the park, maybe suggest that everyone do 2 tests.
So right. So this is, my personal thing. I like the 2 tests to make sure there's not a false miss. But with that said, I would also just encourage that in an intimate group, these people, right? It's not, strangers. If it's a small intimate group, like 10 or so, maybe you don't need the testing, just talk about symptoms and so forth. If it's a big group, then just say, hey, just test, make sure we can all come and enjoy. We bring spirits and enjoyment and not COVID. I think you can use that as a technique, not just for now, but also for the fall. The one thing that's frustrating, on a side note, I was going to bring this up, is these variants seem to time themselves with holidays.
The Alpha did it with holidays.
Yeah, the Alpha did it with the Chinese holidays. So everyone went and traveled, and Omicron came right around Thanksgiving. It's frustrating. But I promise you, we can be a step ahead of Mother Nature. We know this entity. We know how it spreads. You can't fool us, right? Masks, talk about symptoms and so forth. Use tests as a strategy, I would say, for really large gatherings.
Yes.
That's how I would approach this. And again, it doesn't take your chances to 0, but it lowers it so down there that we can just all enjoy ourselves.
So this is a related question. I know that I traveled recently and needed a PCR, and it took 3 days. It was supposed to take 48 hours and it took 72 hours to get the results back. And I think that a lot of people, when you talk about this testing strategy, they're willing to do it. People want to be safe. They want to be in an environment where they know everyone else who's attending an event is also safe. However, the challenge is with PCR results, sometimes it takes longer to get those results back. So, Dr. G, your strategy suggests that people can do 2 home tests. And we know that you can get 8 tests from the government free a month, I think, right? So would you recommend that people just have a self-test with the home test if they can't get the 72-hour PCR test instead?
Yeah, so stock up on those home tests. Or if the government's giving out, take it. And keep in mind, and if you guys have any concerns, you're like, but there's an expiration date. You have to understand the expiration dates were thrown out to begin with because it was the first test, right? It was the first SARS-CoV-2 test, home test, right? So they slapped on a 6-month expiration date because they just didn't know. People didn't know how long, we didn't know if there were going to be new variants. So what I'm alluding to is these tests are probably good for years to come, as long as they're properly stored and so forth. So stock up. That's what I would say. The PCR, I think, has a place.
Yep.
It does. And if you're having a company that wants PCR, email us. Like, I'm happy to help justify. You don't need that. PCR is a very overly sensitive test, and there's only very few patients that I actually would recommend that. If you have symptoms and you're fully vaccinated, home test is perfectly fine to get. Keep in mind also the PCR picks up virus. So what do I mean by that? The home test picks up a property of the virus when the virus is alive. This is really key because that means the home test is picking up a live, living virus. Mm-hmm. PCR will pick up remnants of the virus. So that's another frustration. People are like, oh, my PCR is still positive, 3 weeks later. I'm like, no symptoms. That's probably, I promise you, it's probably just picking up dead pieces of virus. And sure enough, when we ask the lab to run a very specific test, that's what they find. So from my standpoint, the rapid tests are the test for people to live their lives comfortably. Yes.
Okay, so a related question from one of our Facebook guests is, if you have an immune compromised system, are you going to test longer? And are you contagious longer as a result? Is that what's happening because you have an immune compromised system?
All right, that's a great question. I love this. Man,
it is a great question.
I love this crowd. Yeah. So the challenge with being immunocompromised, and I apologize for how I'm going to approach this. Like, the immune system is very complicated, right? Are you immunocompromised because you take 5 milligrams of prednisone, or are you immunocompromised because you just went through chemotherapy and you have no bone marrow? So there's a spectrum of that. So the first thing I would ask, and this is where you might be like, oh, he's copping out. No, but talk to your doctor, like where you stand with your level of immunocompromisation, because for certain patients, being immunocompromised, that where they're at has nothing to do with the viral situation, right? They're just disconnected because the part of the immune system someone may have weakened doesn't impact infections, for instance. And we see that a lot of that, for instance, in patients who have allergies, right? We will weaken their immune system and we'll tell them, yeah, your immune system is a little bit weaker, but it has nothing to do with the viral, getting a viral infection. It should be just as robust as the general population. So the first thing I ask is just talk to your doctor. What does it mean if you tell me I'm immunocompromised? Does that impact the virus? Because for some people, you're spot on, especially like our lung transplant patients, they can be positive for up to 3 months. Yeah, they're probably still contagious up to those 3 months. So it is worth having a conversation with your doctor where you're at in the spectrum. Some people being immunocompromised, again, it just might mean for a very specific part of the immune system where from an infection standpoint from a virus, you're still just fine as the general population, and others, no. You got to take extra precautions.
So what's happening in our schools is that, the COVID testing has been really expensive and exhaustive, I think, for some of our school personnel. So if schools are deciding not to do as much testing in the fall, because I think that a lot of schools feel that they have successfully managed their COVID strategy over the last year, what would you say in terms of like parents, resource parents, what would you say they should be doing if the only way that many parents are going to find out that students even have COVID is through schools, and schools are relaxing their COVID testing strategy?
Yeah, I mean, from my standpoint, I would really just encourage schools to maintain a level of transparency, where we're at with COVID numbers and so forth. because you want parents to make the best informed decision for their children, right? Schools are going to have a lot of children who are immunocompromised, a child who may be going through their first treatments for lymphoma, right? So no school, I mean, if schools drop a little bit of the lackadaisical approach towards COVID, at least maintain some, and I wouldn't encourage that, but you got to maintain transparency so parents can make the best decision for their child at all times. We can live with this virus, and we can live with it no different than, the analogies I give here. It's like you drive a car, right? You know the best way to get into a car accident is by getting into a car, but we do it, and we can do it safely, and we can do it every day without a car accident. Same thing with schools. Just be transparent. COVID is still here. I wouldn't drop your guard on, scaling all the way back, but there are ways that kids can still feel normal. Just as our colleagues here talk about their mental health, they can live normally with COVID, right? 100%, we can adapt to this, and we should. Just don't rob parents of the ability to make the best decision for their kids. Yeah. You'll rob them of that if you don't maintain that level of transparency of what is going on within our walls of COVID.
And so, to that point, I want to extend out to our other guests, Mr. Liggett-Creel and to Ms. Chester, how, for families that are trying to manage this COVID testing and school situation, how can the resource families really help the children in their care to be able to stay safe with the shifting sands beneath the testing requirements? I think that's been a piece of the COVID fatigue, to Ms. Chester's point earlier about why we're tired. Everything, it just continues to change. And so what do you suggest that resource families do as these requirements continue to change?
I think for me personally, I decided that regardless of what the school was going to do, I was going to have my kids follow wearing a mask and doing all these other things. So where they went to school, everybody stopped wearing masks, but my kids continue to wear masks. They wear masks at summer camp, and a lot of times they might be the only one in the room with a mask on. I make sure they wash their hands. So I tried to keep them as safe as possible by, making sure they stay masked, make sure it's appropriately on their face, and explaining why they have to wear the mask and why it's important and why they can't do what their friends are doing, right? And so it seems to be working. They're 6 and 3. So, the best way you can go about it seems to be working.
Well, I think that's how most parents feel, though, honestly. I mean, I think we just say, well, we're doing the best we can, and it will take it from there. Thank you. Mr. Liggett-Creel.
Yeah, I think it's just having that conversation and again, you have to adjust according to the child's age, right? And so if you're talking about older kids, you should already be having conversations around setting your boundaries and not necessarily, the old adage, friends jump off a bridge, would you jump off a bridge, right? Like concept, right? It's having that conversation, but also being clear around the need to be safe, what wearing a mask can mean, and just having that open dialogue around regardless of what the schools may do, or if you're going to an event with, your peers, what can you do? Here's the things you can do to be safe, right? And, hopefully many of those households have taken advantage of the vaccination. So, if something does occur and COVID does enter the picture, right, that they are as protected as possible from what the vaccine can do. But again, using that mask and really just being clear around the boundaries. Again, similar to what parents are doing with other aspects of raising children, right? It's just an added conversation that has to happen around there is this thing, and doing in a way that doesn't create fear mongering and again exacerbate anxiety and fear. I think the opposite can be true too, right? Like in my household, there's certainly a decline in mask wearing in certain contexts, but respecting if, I have a child who continues to wear the mask way more than the rest of us, and respecting that and saying, okay, that's what you need to feel comfortable when we happen to go out in the outside public area. But if that's what you need, and that's okay, right? And there's no judgment or concerns around that. So I think, again, that's, it just goes, again, back to a conversation and really helping a young person understand, but also understanding that there is going to be challenges with that. And what are the other tools you have available to you, right? You have, if you believe there's some testing, and again, understanding science. I know some parents have said, okay, I'm afraid my child was exposed today, and they test today and it's negative, so they say, okay, we're good. Well, that's not really, that's not really how that testing might work, right? Same day exposure doesn't mean symptomology and positivity for today. So it's about having those tools and available to you. And again, using the professionals in your life, using the medical professionals in your life, using the therapists and mental health providers and the resource parents, using their staff when they have questions or concerns or need resources to, again, create this space in their household that's necessary, understanding they can't control every aspect of entry and exit into their household, whether it's the child's age or the fact that their child still has to have visits with their bio family. So it's exiting the home, going into another household, and then coming back. And again, it goes back to that relationship and dialogue.
That's important. Thank you. Thank you for sharing that, Mr. Liggett-Creel. Dr. Galiatsatos, I want to come back to you, and then I've got some really heavy questions for both Ms. Chester and another one for Mr. Liggett-Creel. For you, Dr. G, I want to talk about long COVID and kids. What do we know about long COVID and kids? I mean, even though we are seeing, I think that people are less afraid of COVID because we have seen the death rate from COVID plunge, but we are still seeing that people are being affected by COVID. And this notion we talked about a while ago about Miss C and kids. And so that was borne out to not be as much of a problem as we thought it might be. But now we're still seeing long COVID as an issue for a lot of people. And as Ms. Chester said earlier, you're seeing so that there are people who are becoming disabled because of this and not able to work. And we are worried about that prospect in children. Give us some more information about long COVID in kids, Dr. Galiatsatos.
No, of course. And you guys are, I mean, what I enjoy about these conversations is, the recognition that, appropriately, the fact that we've all assimilated to some extent COVID, we made it non-life threatening. That's fantastic. It's still life disruptive, right? When I talk about catching it, yeah, it's a bad cold, you're at home. That could be 14 to 21 days of missed work. It's huge. And back in May, I was invited to this great seminar as kind of an invited speaker. And, heads from Walmart to Google were all there. And they're like, what do we tell our employees? Because they're concerned, right? It's not just a matter of missing a couple of days of work with COVID. The long COVID is really rattling a lot of employers, right? Because they're like, is this a disability thing now, et cetera? So let me first just mention this. Viruses and long-term consequences are not new. You catch polio, the immediate effect is a lot of GI discomfort. Guess what? A lot of people then ultimately become paralyzed, right? It's got a longer consequence later. We know about chickenpox and then shingles later. And if it wasn't for the pandemic, I promise you this, the bigger conversation from a virus would have been the Epstein-Barr virus, the EBV. Virus that caused mono. And how many of us right now, I say mono, a little dismissive. You're like, yeah, it's a high school thing, or, we found out it causes multiple sclerosis. If I told you that, how many people would suddenly be like, we got to vaccinate this thing. We got to get rid of it. Or HPV. HPV doesn't kill you, but it can cause cervical cancer. It can cause a variety of cancers later on. Long-term consequences of viruses are not new. They do this. They undo the immune system in some different balance. In COVID, there's going to be some very similar viral biology that we're going to see in COVID in kids, right? Not long COVID, we'll get there in a second. But one thing I want to tell every parent is lung infections, bugs that want the lungs, like COVID, my fear is it can rob the child of the ability to really have their lungs evolve to their peak. Your lungs continue growing until the age of 35. Right? So they got a long way to go. You want them to have the best lungs out there. You know what will rob them of that? A bad infection, right? Where a kid suddenly is on that trajectory for normal lungs, lung infection will make them deviate from that. So that's one thing I want to make clear. Like, yeah, it could be a bad infection, bad cold. It could also rob the child from really reaching their health potential. We don't want that in kids. And long COVID, by all means, We're finding out more and more about this. And my pediatric friends are the ones who are relaying this back to me, because I deal with long COVID a lot more in the adult population. It's devastating. You know, it robs people of their quality of life. They have these kind of symptoms that they can't really put their finger on, and we don't have an intervention for it, right? That's what's bothersome. So for the adults, we teach them how to adapt. It's kind of like patients with ALS or multiple sclerosis. I can't cure you, I can help you adapt to it. So from my standpoint, we do see long COVID in children as well, in addition to some other post-COVID complications. The big thing that I want to just put out to the audience here is COVID will rob the child's health. For how long? It could be permanent. And we really don't want that as a society on our heads, right? And I see this because it's not, right? This isn't like, it's not like a volcano erupting. You're like, oh, woe is me. This isn't Pompeii. This is preventable. This is preventable. So just keep that in mind as we protect this next generation and make sure they get their best potential out of life. And that one way is making sure they don't get COVID.
Thank you, Dr. G. Okay, I want to turn now again to Ms. Chester. Ms. Chester, one of the audience members had a really good question about how responding to the pandemic has improved potentially the child welfare system. Do you think that the child welfare system has had any kind of change that has been impacted in a positive way as a result of having to deal with COVID?
I think with COVID, we started to pay more attention to the kids we serve, right? So we might do our regular check-ins, do our regular routine, like, hey, everything's good, okay, you and the parent getting along, okay, great. But with COVID, I think it made us really focus in and pay attention to who we were serving, whether you were a therapist, whether you were a child welfare worker, but just being more in tune and not just doing the job, because now we're feeling the same thing they're feeling, right? And so we know what we're feeling every day at home dealing with COVID. So it makes us more aware of, hey, let me check to see how they're getting through, how the parents getting through, right? So I think it helped us kind of have more of that human connection and be able to relate to each other better.
That's helpful. Thank you. And what else would you like to see in terms of evolution of the child welfare system because of COVID? What would you like to also see? You said that now the system you see the children better. What else would you like to see as a result of how this has happened?
Honestly, I would like an emphasis put more on the whole kid versus we have to find them this house, they have to be here, let's make sure they get therapy, just kind of wrapping them from the mindfulness perspective, right? We give them meds for their issue, we send them to therapy to try to fix their behavior, we give them a house because they're homeless, right? But it's more to it than that, right? It's connecting their mind, their body to everything so that they're just not going through the system. And if I could throw it in there really quick, not necessarily COVID related, but kind of COVID related, is after they're 21, I know so many kids who are homeless after 21. So I think this is a perfect opportunity to say, we're looking at it on a long-term basis. So let's peel back and let's break down what isn't working, rebuild, and look at how we get the child from when they come into care to 25, right? At 21, we're dropping them off. But how do we get them to 25 now that we know more tools and resources are needed, period, for these types of things? But if they have nobody after 21, if something like this comes around again, how do they survive? So that's what I would say.
Right. And what support systems are available to them? Yeah, that's an important question too. Thank you. And then to Mr. Liggett-Creel, I have a question from the audience about supervised visits. So for supervised visits, what are the best accountability practices that resource workers can use to support children and make sure that they're thriving while we still are working through this pandemic?
So I think that trying to process the question. So I think from a supervised visit perspective, right? I think one, and again, unrelated to COVID, I think it demonstrates that there's importance to having supervised visitation. There's necessity to have it. I think we learned that there's not just one way to do it, right? That we can have multiple means of communication to have visitation and supervised visitation. So there may be opportunity to do more visitation, but do it differently. So you have your in-person, but you're able to have other contact, because under COVID, we were forced to do different kinds of visitation. So I think it expanded the tools for that. I think it increases collaboration and communication, because as we moved into COVID, we had to ask questions differently. Workers got into a position where they were engaging the biofamily in advance to ask questions. And I think there's opportunity in that model, even if we're not always asking about symptomology, right? We can ask other questions. So as we go into a visitation, supervised or unsupervised, that there's some pre-work that can go into that to improve the outcome. Because in the end, right, our outcome is to move through the visitation so that we can get this child back home and make sure the families are stable. So from a worker standpoint, I think it is, again, it improves the opportunity to build relationship. It is improving communication, and that engagement, I think, is key to that process. And then within that, making sure that we're assessing each person's ability to do it. But again, I think having those tools available really is key. If someone is having symptomology and we're unsure about doing it, it's not just saying, okay, we can't have a visit. We just have to do a visit differently. And you can still supervise a virtual visit or a telephone call, or doing it in not always doing it in an office space, but taking an opportunity to use, if you have parks available, if you have those environments where you can still have those visits and support social distancing. So I think it allowed resource workers, it allowed the social workers in child welfare, and particularly those that do those visitations, it gave them a lot of tools and innovative ideas on how to do it, because they continued to do it even in the middle of the COVID, right? And they just did it differently. So I hope that answers the person who asked the question, but again, that continues to support our mission. Having the visit, just maybe looking at how to do them differently.
That's very helpful. And I think a lot of people are still trying to wrap their minds around, how to continue to be innovative in that. So very helpful. Thank you so much. Dr. G, I want to come back to you with a question about the actual the veracity of the vaccine. So we hear about this all the time in our work with HEAT. People have questions about whether the vaccines are safe. So if you are a resource worker, or if you are a parent or even a bio parent who is trying to answer questions about whether these vaccines are safe, where is the data? Where are the studies that we can use to point people who may be naysayers to, so that they can see this evidence for themselves?
So are the vaccines safe? It's a great question, right? Because you want to make sure, what are we getting, right? You want to do risk and benefit analyses and so forth. The vaccines, all of them that have been submitted to the FDA, Moderna, Pfizer, for all age groups, Johnson & Johnson, and now Novavax, the newest one, they try to recruit thousands upon thousands of patients, because what they're looking for is a signal for safety, right? They'll recruit as many as they think we need to showcase that it works, and they'll recruit more to make sure we pick up as much adverse events as possible. Let me give you, for instance, an example, right? If 1 out of 20 million wins a lottery ticket, well, if 2 people buy a lottery ticket, how rare the win is, they're not going to win. So if you have a bad adverse reaction to a vaccine that 1 in 20 million experience, a research study is probably not going to pick that up. You're going to need to wait for the world, billions to take it, and then finally to see if something does signal. So I say that because when we recruit thousands upon thousands of patients, we are looking to see most common side effects, adverse reactions immediately. We may not pick up the signal for the most unusual side effects, like Johnson & Johnson's version, right? That blood clot, it's about 1 in 16 million. Of course, we're not going to pick that up in a man-made research project. And that's why we have this kind of global conversation about how the vaccines are doing. These vaccines are incredibly safe. I mean that. When I look to see other things that we have done in healthcare world, I've never seen a product so safe, right? The confidence is massively there. Actually, and for many of you with, a child in the 6-month-old to 5-year-old, and you're like, oh my gosh, do I give them the vaccine? Here's the confidence I want to give you. This vaccine, we really promote it for older individuals a lot, right? 70 and older, for instance. In the 70 to older age group, they recruited about a few hundred people. For 6-month-old to 5-year-olds, for both Moderna and Pfizer, about 8,000 kids were recruited. They did their homework, right? They want to make sure it's not just that it works, that we can pick up adverse events, common ones, and to some extent a signal for uncommon ones as well. So yes, where you can just point them to, yes, FDA and CDC and the NIH, these are the companies, these are organizations the government has put together to maintain public trust in what we do. But at the same time, globally, the World Health Organization puts it out. There's tons of entities, even HeatCore and Hopkins, we will put that out as well. These are massively safe. I mean this. And last thing I'll finish with, this week, out of one of the biggest medical journals, Lancet, a great study came out showcasing 20 million lives were saved because of the vaccine. You know the last time we saved that many people in a short period of time? If you're scratching your head and you're like, I don't know, Dr. G, this is a great trivia question to have. The answer is never. This is it. We lived in one of the greatest science outcomes ever.
Wow, that's pretty powerful. Wow, 20 million people. Okay, well, I have a follow-up question then from a parent who asks, what do you do when your child comes home and says that they have a classmate who did not eat breakfast or lunch? Does that mean that they have COVID? And I think that question is important because we know what the symptoms are of COVID, but for children, what should we say to them about symptoms of COVID? If they think, for example, that not eating breakfast and lunch is a sign that the lethargy perhaps is a sign that, a fellow classmate has COVID.
Yeah, so from my standpoint, children will always have their own unique symptoms as compared to adults. And you're right. Sometimes you will see symptoms that are unique. So I know the term I'm going to use, it's going to carry a lot of stigma, but the term of loss of appetite, the medical term is just anorexia. Orexia just means appetite in Greek, and some Greek. To me, that's not a common side effect of COVID in general. It can be for other things. So this hepatitis, right, the unknown hepatitis that we saw going around in kids that we're starting to link, it could be from COVID. You see that kind of liver disease sometimes result in a lack of appetite and so forth. So if a child didn't eat breakfast, it's really more of a conversation of, is it social reasons, or is it really a loss of appetite towards it? And, one of the things that I love about the schools is, you can have a close eye on kids and their norms and so forth. So if you see a kid kind of deviating from their norm, by all means, begin to ask, at the appropriate manner, schools do, how things are and so forth. But a lack of appetite, I haven't seen it as a symptom of COVID. I tend to see it more from its complications afterwards.
Thank you. Well, we are coming close to the end of our time together today. So I wanted to, first of all, say thank you to all three of our panelists, but I want to give each of you all a final word. So we will start with you, Dr. G. Do you have a final word for all of the guests on our webinar today?
Yeah, my final word is, we're all living through this global public health crisis together. Science has the tools, right, to make sure it doesn't take our lives, and the same tools to make sure it doesn't steal our quality of life. But it's up to you all to take this notion and know how to adapt it to yourself, to your own identity, to your family, to your culture, and so forth. You always remember, science is just kind of a string of facts. Mm-hmm. How you use them, really just make sure it's used for your priorities, right? And hoping that priority means health, mm-hmm. well-being, and so forth. So from that standpoint, we've done a lot. And when I say science, I don't mean to make it sound disconnected. Those scientists, those doctors, those are moms and dads, grandparents and grandmoms, right? Those are just human beings doing the best to protect other human beings. So good luck out there. Thank you.
Thank you, Dr. G. Ms. Chester?
So I'll leave you with, you can't pour from an empty cup. In order to be out here and helping families and children, we have to take care of ourselves in order to take care of them. So I would say prioritize self-care, prioritize taking care of yourself, taking time off and doing what you need to do to be okay, because that self-care routine builds resiliency. So if, as you build resiliency, we can survive anything or make it through anything. And so take care of yourself.
That's awesome. Thank you, Ms. Chester. And then Mr. Liggett-Creel, you have the final word.
Yeah, I think that, workers and resource parents in a situation, we learned that what a critical service they perform, right? And that regardless of regardless of kind of what COVID brought, we still had to perform a lot of our duty. And so just recognizing the importance and value of your role, and then utilizing the tools available and, advocating for yourself and what you need within that same context. And I'll just reiterate and ditto what Ms. Chester said, right? It's really having to take care of yourself, making sure families are taking care of themselves. And that whole system, it's a parallel process, right? You got to care for yourself to care for others. Put your own mask on before you put them on to your children, kind of thing. So it's tough work, but it's necessary and it's appreciated. So.
Well, I want to thank all three of our panelists today. I also want to thank the staff of the Johns Hopkins Heat Corps who have helped us today with the production of this webinar. This has been very insightful. And I think that as we've all found, we are in the middle of this pandemic. Hopefully it will be shifting to becoming endemic and less of a pandemic soon, but we still are in unprecedented times. This is the most overused word in history, but it is unprecedented. And so we are finding our way. So we have to make space in communities for events like this so that we can stay connected and stay up to date. And so I appreciate all of you, the resource parents who joined today, the child welfare staff who joined today. Thank you so much for your great questions. I want to thank you for participating. This has been such an active event, and I really do hope that everyone was able to get something out of it. You can follow us on Instagram, Twitter, and Facebook at JH Heat Corps. And if you have any further questions, please email us at heatcorps@jhu.edu. I am Annette Anderson, and I have had the privilege of being your moderator for today's webinar. And I want to thank as well the Johns Hopkins University and Medicine and the Johns Hopkins Health System and our colleagues from the University of Maryland, I believe, have been putting the links in the chat for those of you who have been asked to complete the evaluation. So thanks again for joining us, and please have a great and safe rest of your day. Thanks, everyone. Take care.